this is a very important scenario for everyone concerned, right from parents, nurses to our medical trainees and doctors. So we have a 2 or 3 day old baby in the ward who is otherwise well-term baby, healthy, no risk factors for infection. And the mother calls a nurse to say that the baby has greenish vomits couple of times. The nurse initially thinks it's light yellow, and then the second time it's actually deep green. So she decides to call the doctor to check. So this is a very common scenario. And can you describe why we are worried about a green vomit and what we should be doing in such cases?
Yeah, so green vomit, or what we call bilious emesis, is always concerning. And this is kind of part of my discharge sign out to families, because adults, if you vomit enough, eventually it's going to be green because you don't have anything in the stomach. So people aren't used to how scary it is. But bilious emesis is concerning because it can mean that something very bad is going on. So the thing that we're really worried about in newborns, especially in full-term babies, is that we're worried that there is an obstruction in the gut, or even more concerningly, because this is an emergency. So you could have an obstruction in the gut and, it's okay if you take a couple of days to fix it. But the type of obstruction could be a volvulus. And that is what we have to figure out immediately. Are we missing a volvulus here? So a volvulus basically is where the gut isn't necessarily stuck in the areas where it should be. So that's what we call a malrotation. So there is specific areas of the intestine that are normally in positions. For example, the duodenum is on the other side of the vertebra from the stomach. And then the cecum is, as you all know, right where, like the appendix is or whatever. So in some babies, for whatever reason, the intestines are positioned slightly abnormally. And because of that, they're at much easier risk of coming loose and just kind of like twisting on themselves. So when they twist on themselves, the vascular supply can be cut off. And so the baby does have an obstruction. The baby will start puking and maybe puking green. But more importantly, what we're worried about is if that is a vascular compromise, that baby needs surgery immediately. And the only way to save the gut is to immediately untangle that volvulus. So this is why all bilious emesis in a baby is an absolute emergency. You have to rule out, does this baby have a volvulus? I felt like you were about to say something.
Yeah, I mean, it's you covered the points about why it's important to pick it up immediately. And it's interesting that about 1 in 5 of these babies may end up needing a surgical procedure. And the surgeons are always very keen in getting them quickly, because even if they look well, it takes time for the volvulus to have the ischemic changes and the baby to become sick. So that becomes too late at that stage. And the main idea in these cases is to save as much gut as we can, and without ischemia and without removing the gut if possible, because short gut syndrome is a very difficult problem to manage. So the surgeons are really keen that we shouldn't wait for the baby to be sick, and a baby being sick or acidotic or having significant distension is a late sign in these babies. So don't wait. I looked through the guidelines from the American Academy and other sources, and obviously it's better not to discharge these babies without a clear assessment. GI contrast study is better to rule out a malrotation. Obviously, we don't want to go too much into the embryologic basis of why a malrotation happens, but it's just that the gut has a twisting during the developmental stage. Before it goes back, it develops outside the yolk sac and then it goes back in, and during this process it's incomplete. So one of the ways we can diagnose is also by doing the ultrasound, but you need good expertise, and it doesn't always correlate even if you have. So we are looking at the superior mesenteric vessels, the vein and the artery. And the easy way to remember it is that we often read about the vein structures, vein, artery, nerve, when we read about anatomical relations. So similarly, here it starts with the vein, and then the artery comes, superior mesenteric artery comes to the left of the spine. So the vein comes to the right, and the relationship is that way. But if the relationship is reversed, the vein is to the left of the superior mesenteric artery, then you are going to be more likely to have malrotation. But it doesn't always mean that. Also, some people comment on the bowel gas distribution, but in my experience, I've not found it very conclusive, though they say if most of the small intestine seems to be on one side, you can think of malrotation. So the key thing is you cannot really find out by simple X-ray or even ultrasound. If they're experts doing it, you may have a higher index of suspicion, but it doesn't pick up all the cases. So best if you have definite green vomit, I mean, light yellow vomit can happen. Colostrum can sometimes be yellowish as well, and partly digested milk can become yellowish. But if it is green, the bile dark green color that I think you'll be showing later. So that is the typical color that we should be really cautious. And the key focus should be not to delay. Even though we say 1 in 5 babies will need surgery, 1 in 5 is a very big number. So, and these are babies where if you don't intervene adequately early, you may end up losing a significant chunk of their gut. And short gut is a nightmare to manage, as you'd vouch. So do you want to add anything about this?
Yeah, so obviously, you know, like we say in medicine, we're always like, what is the most common cause and what is the scariest cause? The scariest cause of green vomit in a term baby is a Malro, as of actual, not just Malro, but it's actually volvulized. So we need to take care of that immediately. In a preemie baby, the most scary cause of green vomit, if they don't have a volvulus, obviously preemie babies can have the same thing as term, but more commonly it would be neck. So then there's a whole bunch of other things that can cause a baby to puke green as well. So you could have an obstruction anywhere. The obstruction has to be below where the bile comes into the intestine. So remember, the bile is produced by the liver and then stored in the gallbladder and then dumped out into the duodenum. So if you have an obstruction proximal to that, above that, so say you have a pyloric stenosis, if you have a pyloric stenosis, which is at the end of the stomach, the little sphincter is like blocked or narrowed, then obviously you're not going to be puking bile. You're going to be puking juices from the stomach, right? The obstruction has to be after the duodenum, basically, to actually have bilious vomiting. But really, any obstruction, whether it's actually anatomical, like a volvulus, where the intestine is just coming to a stop, or any atresia. So you could have a duodenal atresia, you could have, like in the double bubble signs, you could have an ileal atresia. If you have a colonic atresia, it might take a few days, but you might end up with bilious emesis. Or it could be more of a functional, like it's not an absolute anatomical blockage, but rather the intestine isn't squeezing down. So if the baby is septic, then the intestine isn't going to be undergoing peristalsis. So a baby's puking green, you should probably make sure that this baby isn't septic. Maybe the mother got a bunch of narcotics during delivery. Maybe the mother got magnesium during delivery and they're still inside the baby and kind of slowing the gut down. So there's lots of reasons that could actually slow the gut down as well. So a lot of them can be actually checked by checking a CBC to make sure that whether we're septic or not, sure, maybe a mag level as well. Get an X-ray, see if there are signs kind of consistent with an obstruction. If you see air throughout and then there's air in the rectum as well, then it's less likely that this is some sort of anatomic obstruction and more likely some sort of ileus. And then again, we should get a contrast study because we should be making sure that this baby doesn't have a volvulus. Or even if they do have some sort of atresia, it would be nice to know at what level we think that atresia is at.
That's good. And obviously, this is the approach most of us follow. And if you don't have facilities for a surgeon or the radiology assessment with a contrast, better to transfer the baby to such a center. I mean, and don't delay thinking that the baby looks well or the X-ray looks well, because these are huge medico-legal liabilities as well. And one important point I would like to make with in terms of obstruction, I've seen some cases where the stomach has a lot of meconium at the time of delivery because of an atresia, for example. And one practice in some of the developing parts of the world is to suction the stomach contents. So never do suction for the stomach contents. You can put a feeding tube and or a large bore feeding tube and aspirate as many times as you need. But just because the stomach looks very distended, don't put a suction catheter in, because a suction catheter delivers a very high level of pressure and there is going to be mucosal injury and you may risk gastric perforation and things like that. So I don't think you will face that in the US, but in many developing parts of the world, they often put a suction catheter, connect to the wall section to empty the stomach contents, which should never be done. Even if the stomach is huge, always use a syringe to empty the stomach as well. So this is one tip related for the developing part of the world. So we have reasonably dealt with, of course, these babies, any baby with the gut obstruction has a gut distension, and there is a risk of wall ischemia. And that's one of the reasons why we focus on giving antibiotics in these cases as well. So nil per oral antibiotics, keeping the stomach decompressed. You may put a large bore feeding tube and regular free drainage. And I mean, I don't know if you monitor the intestinal, the abdominal girth, which may or may not be helpful. So these are things which practices might differ as well.